This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. Now, I'm going to welcome you to our special Journal Club series episodes here on PHM from Pittsburgh. For those of you who are new, welcome. But for those of you who've been here before, welcome back. We are a continuing medical education podcast started in October of 2016 here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. Now, we have been coming to you discussing different topics on the American Board of Pediatrics content specifications for pediatric hospital medicine and some contemporary topics that have come up and demanded our attention, like everybody's favorite virus, COVID. But one of the areas we have been trying to figure out how to cover is the research part of the content specifications, both for PHM and general peds. It's a challenge, right? You have to learn how to critically evaluate the literature. And as you can imagine, it's made doubly hard trying to do it in an audio-only podcast format. So to pull this off, we have partnered with our colleagues at Dell Children's Medical Center and our guest for today, Dr. Philana Lin, and a group of experts, both from the University of Texas at Austin and the University of Pittsburgh. And you've been meeting them and you'll continue to meet them throughout the series. We couldn't have done this in any way, shape, or form without their help. But as I kind of already spilled the beans, our expert for today. Now, today's episode, before I introduce our expert guest, is a hodgepodge of topics. These are topics we want to cover, but couldn't create a specific episode for them. So it's a smorgasbord for you. It's a charcuterie board, if you will, of topics here for Journal Club. We are going to talk about incident prevalence and incidence, and then we're going to talk about some definitions for types of research studies and subtopics and some definitions within research studies. So without further ado, our wonderful expert guest is going to walk us through this. Dr. Philana Lin is an associate professor at UPMC Children's Hospital Pittsburgh in the Division of Pediatric Infectious Diseases. She has a master's in clinical research from the University of Pittsburgh. She does wear several hats. She's an accomplished physician scientist with expertise in the host pathogen interaction with Mycobacterium tuberculosis and tuberculosis HIV co-infection. She is the site PI of a nationwide multi-centered pediatric study group examining the changes in the seroprevalence of invasive pneumococcal infections in children over the last several decades. And as the Pediatric Infectious Disease Fellowship Director, she's deeply committed to clinical research and academic education of her fellows. She's also been my partner on all of these episodes. So, Ling, welcome and thank you for joining us again.
Nice to be here.
All right. Now, Ling, we have to do our disclosure statements for this is a CME podcast still. I will go first and kick it out to you. I was on... And for the Sanofi Corporation, I was on the meningococcal vaccine immunocompromised advisory board. So meningococcal vaccine in immunocompromised patients advisory board, which should not have any bearing on what we're doing now.
And I, some of our pneumococcal studies were originally sponsored by Pfizer, but it was PI driven or investigator driven. So it has absolutely no influence on what we're going to talk about today either. And otherwise, I have no conflicts.
Well, Ling, on every charcuterie board, I go for the meat first. So why don't we do that and do, if you're okay, you want to start with incidence and prevalence?
Yeah, sure. So I think that everyone probably remembers basic epidemiology in medical school, but if you don't, if you can remember the nightmare of COVID, we would get reports on a weekly basis, right? We would talk about the incidence of COVID, which basically by definition is the number of new cases. So brand newly diagnosed cases over a specific population or over a specific time. So if you remember during the throes of the beginnings of COVID, we would get reports of these are the number of cases we've had this week or the new number of cases we've had this week. So that's the incidence. And then they would give you the total in the United States since the beginning of the epidemic. And those are old cases that may have been diagnosed several months ago, including the new cases that were diagnosed this week. And so that's the prevalence, right? So the prevalence is the total number of cases. They don't necessarily have to be new. They can include the new cases over a specific population or specific time. So sometimes people would say point prevalence, which basically is the number of cases over a certain time period. But if you can remember, incidence is new cases, prevalence is existing cases, then it makes sense that the prevalence would be larger and a larger number in general than the incidence. So incidence is new cases, prevalence is the total number of cases. And that can change over time. Luckily, we haven't had the race against time with COVID, where we've been tracking new cases by day or by week. We're a little bit maybe COVID fatigued right now. But those things are important. And they're sort of like the bread and butter of basic epidemiology.
So if I have this right, Link, so incidence is the new cases over whatever time period we choose. So it can be daily new cases, monthly new cases, whatever we choose. But prevalence is the total number of cases in a period of time, not just new, old ones as well. So the prevalence of COVID, the best examples, COVID was how many we total had, and the incidence could have been how many new cases for that day.
Right. Oftentimes, so it can be by time period or it can be by total population. So sometimes if you look at like the CDC website and they look at, let's say, flu, you might see 5 cases over 100,000, right? So over like the denominator of a population. So typically you'll see an incidence or prevalence per 100,000 population, for example, or per million, for example. So it can be over, the denominator can be over a population or it can be over time.
So the denominator can be population over time for incidence and prevalence. Okay. I think I got that. That's pretty straightforward. I'm not sure how they could trip me up with that, but I'm prepared. Moving on our charcuterie board here, let's go over to the cheese. We want to do some definitions for research, whether studies or within the research.
Right. So let's just touch base on a couple of very basic types of studies, and these will be familiar to you from medical school. So let's say I am interested, I've discovered a new disease. There's a child who's coming in with purple eyelashes, and I've never seen this before, and I want to try to understand it. So there are descriptive studies. So a descriptive study is, let's say when COVID first came out or when MISC first came out, there's studies that basically say we had this population of, let's say, 20 patients, and we're describing essentially what the natural history is, what the progression is. Did they have a prodrome of cough, congestion, runny nose, and then they developed purple eyelids? How long did the purple eyelids last? Were there any factors that were involved in terms of risk factors? Did they, after the purple eyelashes went away, did they resolve and were they completely back to normal health? So that's a descriptive study where you're identifying a new disease, for example, and you're providing the field basically of what you've learned from that new entity or new disease, right? So we saw this quite a bit with MISC, right? Soon after we saw COVID. So if we wanted to delve more into trying to figure out what are the factors associated with purple eyelashes, which is our new disease, we might look for what are called case control studies. And so in this particular scenario, we would pick children, for example, who had purple eyelashes, who had the purple eyelash syndrome, and those who didn't, and try to look and see what are the factors that distinguish them, right? So we would find out from these retrospective studies, because they tend to be retrospective, did it have to do with exposure to being in the pool? Did it have to be, was it related to how old they were? Was it related to what gender they were? And so case control studies will pick a population of interest and then a population that doesn't have the disease of interest and try to compare the two to come up with risk factors.
And this is purely for risk factors, case control studies. So we're looking for what could have in some way been associated or causative for our new purple eyelash disease.
Right. And this often, actually, classically in medical school, they talked about the the NHANES group, right? And they would look, for example, people with cardiovascular disease versus people that didn't have cardiovascular disease, and they would try to look for risk factors, or cancer, for example. So those are case control studies. There are cohort studies. So these tend to be more prospective, where they pick two populations and follow them over time to see who might develop the disease of interest and who might not. These are thought to be more rigorous because you have control over these groups before they get the disease. You tend to pick groups that may or may not have an exposure that you're suspicious of, right? So you tend to have more information about what the risk factor is with cohort studies.
So in our purple eyelash example, then first we would do the descriptive studies. It's never been seen before. Then with some time passing, we would do some case control studies. And once we have some what we think are risk factors based on our case control studies, we could then do a cohort, which is our first prospective trial, to test our associated factors, see if we were right. Is that fair to say?
Yep. And then with a cohort study, you would be picking specifically two groups with the risk factors that you thought were associated with purple eyelashes. So let's say purple eyelashes we find out that there are a couple that the biggest risk factor is, let's say, red hair, right? Mm-hmm. So you're going to pick a group with red hair versus those without red hair, and then follow them over time to see which ones actually develop purple eyelashes or not. And then one of the ones that was discussed before was a randomized control trial, and that is probably the most rigorous of tests to look at, actually to investigate a number of different things. I think with randomized control trials, they're really best for a treatment study, right? You have, let's say we have a new drug, we'll call it, I don't know, drug A. So let's say drug A works for purple eyelash syndrome. And so we're going to take kids with purple eyelash syndrome, and half of them are going to get placebo and half of them are going to get drug A. And it's going to be double blinded. So the kids don't know what they're getting and the physicians don't know which drug they're getting. And then we'll look at how quickly it resolves amongst the group. So that's probably the most rigorous. And the randomized controlled trials tend to be prospective, of course, and interventional.
So prospective, looking ahead in time, not looking back. And then interventional, so we're looking at treatments for the disease. So really to figure out working through this again, to figure out if red hair really is associated with purple eyelash syndrome, we would use a cohort study.
Right.
Once we've figured that out, once we've analyzed that, it's a prospective study, we figured we are correct that it's associated, someone comes up with drug A that may be helpful, then we'd use our randomized control trial.
Right. Now, with every study, one of the most critical things is the inclusion and exclusion criteria. And this can sometimes drive people crazy, but it's very important for any clinical study. And even, honestly, any scientific study. You need to know what the inclusion exclusion criteria are because, one, it allows you to address how rigorous the study was, and two, how generalizable it is for you, right? If I am in Alaska and I see a patient with purple eyelid syndrome, but purple eyelid syndrome has only been diagnosed in, let's say, 80-year-olds from Tibet, and the description is from 80-year-olds in Tibet, I don't know exactly whether or not that's going to be generalizable to my patient population or not. How closely will it resemble, right? So the inclusion criteria, when you, let's say we're worried about this purple eyelid syndrome, the way we've seen it in both boys and girls, and they tend to be, let's say, elementary school age. So I'm going to include in my study boys and girls of elementary school age, of hopefully even distribution, right? An equal number of boys and girls. I probably want to know, for example, whether or not, let's say, how about ethnic background? Are they, is the population of equal ethnic background in terms of how generalizable it might be to people who read the study? Or do we know it's only in one specific ethnic background? And then the exclusion criteria might be things like people who don't have eyelids, right? Like you can't really measure purple eyelid syndrome if you don't have any eyelids. And so you want to be very thoughtful about the inclusion and exclusion criteria, right? If you're only going to focus on studying kids of elementary school age, then the exclusion criteria should exclude anyone, let's say 5 and under, and should exclude anyone, let's say 10 and over, for example, right? So how well are they able to include or exclude a very specific population that you want to study?
And this is helpful because if I'm a geriatrician in Alaska, having a school age study is useless to me. I don't know if it works, but a real life example for us, the fever in the kids under 60 days of life guidelines, one of the exclusion criteria is RSV bronchiolitis. So if a patient comes in with fever at 40 days old who has RSV, we know they're excluded from those fever in the neonate guidelines. And then inclusion criteria would be of the right age with a fever not attributed to RSV. So we'd know those kids would meet, but a 61-day-old or a 70-day-old patient would not be in that because they're not in our inclusion criteria.
That's exactly right. And you're going to be very specific about your definition of what a fever is.
Yeah.
Right. So all those things matter because, let's say in one location, the definition of fever is different than the other location. So by you specifically defining what your definition of fever is, you've made it very plain. The idea is that when you write methods, the reader should understand exactly everything that you've done so that they could, in fact, even replicate it if they wanted to. Right. So you don't need all the details, but you need the more critical details, and you need to be very specific about them. And so that gets into sort of this idea of measurement, right? When we define fever, there's a very specific number that's non-negotiable, right? We can say, is it in Fahrenheit or in Celsius? That's fine, but we still know exactly what that fever is. If we say tactile fever, that's not very objective, right? And that's also difficult for anyone else to be able to replicate this study, and also difficult to interpret the data. So when it comes to measurement, objective measurements are the most critical, oftentimes measurements that are universally accepted, right? If someone made, let's say,
the Tarchichi scale for temperature.
Right. So if the Tarchichi scale for temperature is well, or is it the same as the temperature as a fever that's defined by the American Academy of Pediatrics, or is it on a completely different scale? Right. And so those measurements are really critical. And usually certain measurements have to be universal to the experts in the field, right? Yeah. Otherwise, something's going to be critically reviewed and will not do well when it comes to peer review.
And to our listeners, this may seem straightforward, but a real life example that comes up regularly is hypothermia in infants. There is no clear-cut defined hypothermia temperature. Different societies have different things. It runs between, it's either 36 degrees Celsius or 36.5. You'll see different things, under 36 or under 36.5. So if you're looking at a specific study to use as a basis for your treatment for infants or workup for infants with hypothermia, you have to look up their inclusion criteria to see what they defined it as, because different studies will have different definitions to know if it makes sense. So I have this comes in handy on a regular basis.
Yeah. And it can, having the right measurement can be critical to a study. And so that gets to like the primary endpoint. When we look, primary endpoints are the most critical part of any clinical study. Let's say, for example, when we talked about the randomized control trial where we were testing drug A, for example, the primary endpoint for that study would have been resolution of the purple eyelashes, right?
Yes.
But so that has to be very clear. What can sometimes happen is that you'll get primary and secondary endpoints. Secondary endpoint. Let's say you couldn't go to school because you had purple eyelashes. So one could say that was a secondary endpoint. And we were trying to compare, for example, the number of days of school missed because of purple eyelashes as your secondary endpoint. And your primary endpoint was whether or not you got resolution, right? So sometimes you can have secondary endpoints that are less meaningful but still important, but your primary endpoint has to be your benchmark. So, for example, sometimes this actually ends up being really critical. I'm trying to think if there are studies where the primary endpoints wouldn't matter. But if we use your hyperthermia example, right?
The hypothermia?
Right. So let's say, what are the downsides of hypothermia?
Well, in the studies that have been done, the concern used to be when I was training that a cold baby is more likely to be septic or have serious bacterial infection than a febrile baby. That was always what was taught. So the fear was always if the baby's hypothermic, they're more likely to be septic. That was in the old days.
So if we looked at, so let's say we did a study on hypothermia, what would our primary endpoint be? What do we care the most about?
I would say serious bacterial infection. So blood in your CSF.
Right. And so that primary endpoint would be how you would determine your sample size and measure your statistical power, for example, is what's the estimated, usually have some preliminary data. What's the estimated rate, for example, or number of cases of serious bacterial infection associated with whatever you designate as your definition of hypothermia. And then from that, you would calculate what your statistical power is and the number of patients you would need in each group. So that primary endpoint is actually really important. Now, someone would say, oh, we designed a primary endpoint for coming to the hospital. Well, that's not a very good primary endpoint because almost every kid's going to come into the hospital. So really the primary endpoints should make logical sense. These are important parts of why you're going to do your trial, right? And so sometimes when you're looking at articles and you say, oh, here was the primary endpoint, I don't know that that primary endpoint is relevant to my patient, then look for another article that might have a primary endpoint that you're specifically looking for. And then the last issue, oh, go ahead.
Since you have a lot of experience with this, when you're designing these studies, your primary endpoint, you have to know before you start. I'm assuming your secondary endpoints, you also know before you start. You don't pick them up later on when you're getting data collected.
That's correct. When you propose a study, you have to know what type of study design it's going to be, what population you're focusing it on, so that has the inclusion-exclusion criteria, what primary endpoints you're going to use, what are the secondary endpoints you're going to use, and what statistical analysis you're going to do, right? So everything has to be decided a priori. You can't just do it on the fly.
Yep.
And it's all, driven specifically by a hypothesis. So if you have a new disease process, that's sort of easy to peel apart, but takes a lot of time and energy. And then the last thing I'll say, which I know is a separate podcast, is variables. Is it continuous variable? Is it a nominal variable? How are you going to go out and how are you going to measure it? Can it be objectively measured? And that's not to say that you always have to have numbers. Remember that there are a lot of clinical trials and especially psychosocial studies that have been done that will focus on certain things where they don't necessarily use numbers or objective findings, but they have figured out ways that patients or parents can do something at a graded scale, for example, and so they can use those scales. But nonetheless, they are sort of rigorous ways of asking a hypothesis-driven question. So I think that actually, I don't know, I think to the astute parent, they might ask you what the data are, and you can sort of explain it to them.
That's been happening more and more on service. Since COVID, parents have gotten a crash course in education on research, some good, some bad, but they're all asking.
Yes. I think that it's important for us to try as much as we can to be open-minded and try to answer as honestly as we can. I was just in a teleconference. It is February the 6th, 2024. There was a SHEA teleconference on Sunday in which we were talking about the fact that the rates of vaccination have gone down tremendously since COVID, which has led to a lot of issues. So there have been 23 cases of measles from December through January of 2023 to 2024 in the United States. In Europe, there have been 30,000 cases of measles from January through October of 2023.
Oh, wow.
So we have to do our darndest to really educate our parents to make sure that they are looking out for their children as much as they can. And that includes vaccination.
Yeah. And for those of you listening, if you're worried about what Ling just brought up, we have 2 episodes on measles because of the last measles outbreak with Dr. Andy Nowak on the podcast. And if you're wondering if hypothermia is still an increased risk for sepsis, spoiler alert, it's not. But we have an episode on that also with Dr. Andrew Nowak, pediatric infectious disease attending, also on the podcast. So look back through the older episodes if you can find those. But yeah, I think that's true. We need to, and we, I think but we need to more COVID, the pandemic changed everybody. We have to adapt and be able to explain the data behind what we're recommending. And that's part of the reason for these episodes. So if you've been a physician or you're a new physician and you're not too comfortable, that's the point of these. Hopefully, these episodes help you be more comfortable talking about the data. Well, Ling, that's kind of a natural stopping point, but did we cover everything you wanted to cover?
I think we did. And I'm hoping that this is sort of like a light,
fun episode
review, right?
Yeah.
Of the basics of it.
Yeah. The charcuterie board, they're never heavy. They're light. They're they're an appetizer. There's something you have in the beginning.
That's true. That's true. Unless you're like me who goes straight for that stinky cheese.
I do not like the stinky cheese. All right. Listen, this was an outstanding episode. Ling, thank you so much for joining us.
Thank you.
All right. We'll see you next time.
Thank you for joining us for this Journal Club series at PHM from Pittsburgh. We want to especially thank our expert guests for their time.
Special thanks to the University of Pittsburgh for sponsoring the CME for this podcast, and UPMC Children's Hospital of Pittsburgh for supporting this podcast as well. We want to thank our friends at Dell Children's Medical Center and the University of Texas at Austin for their partnership on this endeavor.
Please email my dad at tony.tarchichi@chp.edu with any questions or comments. And as always, thank you for listening!